is because we've got the maternity assurance group, and then we're going to talk about MIS. We're going to do the maternity assurance and then MIS, and then I'll come back and do the state staff, the biannual report with everybody. So for the maternity assurance group, there are a couple of things to highlight. As you can anticipate, we had a great deal of attention and activity focused around the maternity incentive scheme. As you know, it forms a significant part of CNST and the relevant safety actions and our progress against those. Out with the MIS, there are a couple of things just to note. We have reported to board previously that we anticipated in December and January an increase in births. While we've seen an increase, it hasn't been as large as we anticipated, and has been managed very well and effectively. The other thing to note is that we've looked at the feedback from our service users on the antenatal day assessment unit, and we're having a review of the processes and waiting times in that particular area. We would hope that we will be able to report back a reduction in those waiting times, particularly for obstetric review. So that's an area of interest. And then the final thing just to note is that we're doing a review of ITU admissions from maternity. We haven't found anything significant in any of the cases when we've done the review. Nevertheless, we've asked for an external colleague to have a look and identify if there's anything in terms of learning that we might need to draw out of that. But certainly, on the review we've completed internally, there's nothing. So I'll just leave that at Mag. Any questions? On the screen, we are joined then by our lovely colleague Nandini, who is our Service Director of Maternity, and I've got Elaine here, who is our new Divisional Chief Midwife, and we're just going to move into the presentation. That is the CNST presentation for Trust Board. Just going to step through this presentation together. Okay, and we've been mindful of Ian's attention to detail. So it's for his benefit that we put all of this detail into the Year 5 submission, and we're going to go through line by line what we're required to do in order to meet the requirements of the maternity incentive scheme. So to be eligible for payment under the scheme, we need to have completed our declaration from the trust before 12 noon on the 1st of February. We want to be particularly precise even on the time. The declaration form is submitted to Trust Board. It has an accompanying joint presentation, which we're about to do with Nandini and Elaine, and it summarises our progress on the 10 maternity safety actions. We've included some of the detail that Joe needs to complete, and our collaboration then with the ICB as we come to complete it. As you'll see, we have given a summary of the overall compliance to the 10 safety actions. Our trust has done really well. Other organisations, as the requirements on the safety actions have changed year on year, we've managed to keep ahead and maintain our compliance. So you'll see that that's a summary of the compliance. So I'm just going to go through safety action 1. And this is that we're using the National Perinatal Mortality Review tool to review the perinatal deaths. We do all of that on time. We maintain all of the standards around that, and we are fully compliant. There are actions 7 to 10 that relate to this, but they're not applicable to hospital circumstances. And you'll see a review of the cases that we brought through PMRT on the next slide. In terms of safety action 2, this is about submitting maternity data set to the required standard. Craig, we've got great thanks with you. When this came in first, we were really anxious about this, but we've managed to ensure that we are fully compliant with all of those requirements. The only exception in that is the continuity of care. That's not relevant to us as we have not, it's not applicable to our Year 5 as we have not recommenced that process. Safety action 3 is about a demonstration that we have transitional care services in place to minimise the separation of mothers and their babies. As you can see, we've managed to achieve all of that. We are enhancing our transitional care pathway, ensure that it's audited every month and it's reported through the divisional CFU. All term admissions to the neonate unit are recorded on Badgernet. We're able to review them. We do have a weekly Attain review meeting to ensure that patients are not admitted inappropriately. And we have a business case that is looking to put a more detailed structure around transitional care, which will be progressing in the next year. So that is safety action 3. Safety action 4, I'm going to ask for some input from Nandini, which is about our obstetric and medical workforce. This one is that we can demonstrate effective systems of clinical workforce planning to the required standard. Now, this is slightly different to the other actions. What it allows you to do to meet compliance is that we have a workforce plan, so where we're not entirely meeting all of the components, we have a workforce plan that is agreed and endorsed by the LMNS, and so our activity then is working to implement those actions. Nandini, can I ask you if you've got any comments that you want to add to that?
Thanks, Yvonne. Sorry, I'm not there in person. I have a gynae clinic with long waiters, which I could not cancel.
Nandini, could I just ask you to pause? We're just turning up the volume. I wonder if I could ask you to start again. I'm very sorry. Thank you.
Okay. No, I was just giving my apologies for not being there in person. I'm in a gynae clinic with long waiters, which I could not cancel. So regarding the obstetric medical workforce, we do not have any short-term locums. We have only a single long-term locum who has the necessary induction. We have guidance in place regarding roles and responsibilities of the obstetric medical team on call, and the consultants are aware of the situations when they're required to attend. And this is audited and presented every month in the CSU meeting through the governance report. And there is also new guidance about compensatory rest for consultants after an on-call. So we are monitoring, the occasions and incidents where compensatory rest is required the following day. And whenever it is required and requested, we have made sure that it's being provided.
Thanks, Nandini.
Thank you.
The other component then about the neonatal workforce, that is about qualified in specialty. So our focus will be, we're fully established in our neonatal unit. Our focus will be nurses do not qualify as neonatal nurses. We've got to ensure that we do that. So it will be of much benefit to the department and to the individual nurses themselves. We'll have a training program that ensures that we have our nurses qualified in specialty. So that's the workforce plan about the neonatal nursing. Safety action 5 is around, is about the midwifery workforce planning. You'll know that we've done the birth rate plus, and we have implemented the 6 whole-time equivalents uplift in that budget. And then there is the maintaining the one-to-one in labour ward, which we have been done for the most part. It's around 99%. So we're trying to get that last 1% to 100, and there is an action plan in place. So,
quick question for me. It's about terminology. When we move on to other reports, we talk about establishment numbers. You just mentioned birth plus 1. What are the numbers we measure ourselves against as to where our staffing levels should be? For example, on maternity.
It's usually this. So birth rate plus is the only nationalised recognised tool for midwifery establishment, and not only just looking at ratios, it looks at the acuity and the change in acuity of your population.
Right.
So women are classified into either groups 1 or 5, both in the intrapartum period, and they're classified in high risk or low risk, or what better phrases, in your antenatal and postnatal period. So it looks at your acuity, not just your numbers, and then applies the amount of midwifery time that should be allocated to each task, depending on your population. And then it's the responsibility of the organisation to make sure that we match the birth rate plus recommendations in relation to where the workforce will be. So you cannot compare organisations because you cannot compare acuity or population diversity.
Thank you. That's really helpful. But my question was more about when we talk about establishment numbers, do they include all of those?
Yeah,
they're not separate numbers.
So on the nursing side, when we go into the biannual safe staffing report, I'm going to talk about something called SNCT, which is the same as birth rate.
And that's the same,
Yeah.
and that's right, I now understand. Thank you.
I'll explain to you when we get into that in a bit more detail. So for the maternity workforce birthright plus, and we meet all of the requirements in that. The big focus for us is the one-to-one care in labour and making sure that that's 100%. So we've ranged between 99.3 and 100 base. So we're fully compliant with that particular safety action. Safety action 6 is that we can demonstrate that we track compliance with elements of all of the Saving Babies Lives care bundle. That's very, very well established in our organisation. The Saving Babies Lives is regularly audited, and we're always compliant. We're all over 80%, which is what we should be. And we're trying to reduce the quarterly care bonds for this reporting period. They're all submitted to the LMNS for oversight, review and sign off in December. So that's fully compliant. Safety action 7, this is about listening to women, parents and families using maternity and neonatal services and ensuring that we're developing our services in a co-produced way. We're fully compliant with that. We have a very strong Maternity Voices partnership. There's a robust terms of reference. The two ladies who lead it are wonderful to work with. They're all chaired and remunerated appropriately, which is different to the adult side. There is a Maternity Voices Partnership Workforce Plan that's already agreed and has been signed off and confirmed by the LMNS. So there is a work plan and a communication plan that includes direct focus on underrepresented communities. And the co-chairs, they attend the monthly maternity governance meetings. They've been doing that since August. They have a monthly meeting with me. So that safety action is complete. Safety action 8 is about producing evidence for the 3 elements of local training plans that are in-house and one-day multi-professional training, which is a core part of this. As you can see, we're entirely compliant on that. These slides give you an overview of what that training has looked like and our compliance against it. So again, that safety action is fully complete with, you can see the participation numbers in the last slide. Safety action 9, is that we can demonstrate the robust process in place to provide assurance to the board on maternity neonatal safety and quality issues. As you know, we have well-developed board executive and non-executive safety champions. We're really visible in the clinical areas, both our contact details, but actually our presence. These are all reviewed monthly at the CSU and at the Maternity Assurance Group, including feedback into Trust Board. We have a monthly staff forum with board-level maternity safety champions that really highlight the issues and concerns and try and tackle them in a straightforward and proactive way. There is a safety concerns dashboard in place, and that's reported monthly and is visible in all clinical areas, so staff can see what the main issues are. Safety champions support maternity team attendance at maternity and neonatal network meetings. We also have cultural surveys that have been completed, been reported through the Maternity Assurance Group. They inform the improvement plans and action plans are in place to demonstrate this approach. So that action is fully compliant and complete. Anything you wanted to add in the review? And then the final one, safety action 10, that we report 100% of qualifying cases to HSIB. And we've got to report on the cases that we reported between May and December. You can see that the dates are there. That's fully compliant. We ensure that we meet all of those actions and it's complete. So just to conclude, we've met all of the requirements. The 2 areas that are additional on workforce plans are to do with the medical and the nursing workforce, which I have summarized. Okay.
Very comprehensive. It's just a comment, really. So Gary asked me quietly what the incentive is for this. So there's a financial incentive for meeting this, and it's quite significant. So last year, because we were compliant, we received a rebate of £591,000. So around 591 last year. We've been in receipt of that for the last number of years. So it's really important to maintain that. And CNST in its entirety is a very significant cost to the organisation. So last year, our CNST, which includes all clinical negligence, was 11.7 million. And in the coming year, it is due to go up £1 million to 12.7 million. So a very significant cost to the organisation. And this is helping mitigate as well as the more important safety aspects.
It may be sort of thinking and reading about the post office lots recently, but sort of the words incentive and then talking about quality in the service. And I think it's just important to call the incentive scheme nationally. Financial rebate or incentive we get is more than spent on all the quality,
That's
quality investments we just discussed. So it's it's not.
So it rebates and it's reinvested.
It's not insignificant that also and other organisations have really struggled to maintain compliance for the internal incentive scheme. So it is it's a testament to the teams that we keep continue to push.
Small side question from me. Do the standards that we're expected to adhere to incorporate elements of the Ockenden report?
Yes.
So as we tick these boxes, we're ticking.
I think this all
Yes.
out.
Yeah.
On the challenge, it gets more difficult each year.
So year on year, they've been changed, so they've tripled over the last 5 years. So as we get national papers, and I'm sure as we get more national papers around 2030, year 6 will have different measurable outcomes, which we will have to adhere to.
Thank you.
I think one of the comments in the meeting with governors yesterday was around the scale of reporting to the board and on maternity. And so we talked about how that policy started post-operative and post the work we were doing, but that also we as a board talked about trying to find a balance of proportionality to what we're doing. But I think kind of where we are landing in terms of compliance and the work we've done in CQC, good. I think are all indicators of the journey that the team have stepped through on in terms of significant work we've done, but delivering positive steps forward in a ever increasing requirement.
I think just again to note formally here, we do have a formal subcommittee item, the maternity insurance group, which meets monthly and it's doing a lot of the work here. So okay.
Thank you very much.
Just that I've got time for sure I can speak offline if you need to speak on call.
Okay, then how long have you been with us now?
6 weeks.
I'm going to ask you for 30 seconds of first impression. There's always a risk there.
I'll come back. That's my first impression. I would come back.
You would come back. You mean you'd come back? Or
I'd
you'd
come back
with
to
an
board,
answer?
yeah.
Yeah, you'd come back. Lovely.
But
That's
Milton
good.
Keynes has been very pleasant to say in the first 6 weeks. I made the right decision.
By your boss.
We get Alison back there. Yes, thank you.
And you're happy with we've covered everything?
Yes, thank you.
Lovely, super, thank you. So performance report.
Thank you, Heidi. So performance report starts on page 200 of the pack. We have included this month the new objective format that we've been talking about in the background. I do extend apologies. I think the scorecard was omitted, but that's been sent round in the meantime. So the intention was scorecard plus the supporting objectives with the narrative going forward. So we will get that shared with you all. In terms of month 8, November, a little bit as Dev said, cast your mind back in terms of what we're reporting today, because it does seem a long time ago. It was the 1 month without industrial action. And as a consequence of that, we did a lot of elective work. We held our performance around the emergency care pathway, and I think consistent delivery you've seen over the recent months, although over time it has been slowly depleting. We still hold our national position, and that's mentioned in the last page of the narrative report. Within that, a huge number of indicators we monitor and lots of safety elements enclosed in that. The ambulance handover performance eroded slightly in month, but we still hold a very strong position in that. Our internal flow, draw your attention to again, continues to improve in terms of our discharge proportion happening earlier in the day. Week on week, month on month, over this difficult period, that has definitely shown an improvement. And my thanks go out to the nursing team on the site operations kind of delivery, which has included boarding patients and reverse boarding patients to keep that flow coming through the emergency department and bedding people.
It may just be worth, if I may, just expanding a little bit on what reverse boarding and boarding is.
Okay.
You want me to talk about
Go.
that? So we don't, so boarding a patient would be putting a patient onto a ward area, perhaps into a corridor, which we don't do in this organisation. What we do is reverse board. And reverse board is, we identify the patients who are potential and definite discharges. And at definite discharge, we'll try and move that patient in a very timely way to the discharge lounge, or we will accommodate them in our in the day room, so that it allows us to move the sickest patient into a bed space in a very timely way. It's been very successful in our organisation. We have managed to avoid the situations and circumstances that other organisations have had to put patients into corridors. So it puts a lot of, it means getting the nursing teams very organised really early in the morning to optimise those discharges in a really timely way. So some of the improvements that you've highlighted in the performance report, like that transfer to PDU and discharges before midday, are really critical to us maintaining a level of flow that optimises patient experience and safety.
So I think as a consequence of that, pleased to report to the board, the escalation capacity, while we've always had some open, we didn't go into our winter escalation capacity until the 1st of January, which was the additional ward area. And I think those processes have managed to do that. Having said that, it would be unfair of me not to note that we do occasionally bed in, and over the winter period, say December and January more frequently, into our rest deck area. We know what that limitation provides to the organisation when we bedded into those areas. So the flow piece is absolutely critical. Moving on to the elective pathway then during the month of November.
But you might just, since for clarification, because people might not understand this, ESTEC is a proper clinical area. It's not like we're putting patients in a completely inappropriate clinical area, but it does have the effect that it messes up our ability to manage some emergency patients the following morning. I wouldn't want people to do or regret. It's not about the quality of the environment so much as.
So same day emergency care, it's ambulatory patient treatment centre where people come in. We have 2 areas of that where we see and treat people on beds or in chairs, but we can bed into those areas overnight when the pressures command to that much. So as John's saying, it's not a full quality experience, but it upsets the flow of our departments. Okay, thank you. So elective, we delivered more activity within the month of November. Our reporting position at the end of November was 80 patients still on the 78-week pathway, with an objective to clear that by the end of last year. So we know we're behind the curve. And on 65 weeks, we were still at 1,141 to clear by the end of March. My regrets, obviously, with the subsequent industrial action that we've experienced in December and recently this week, we will be reporting an increase in those numbers going forward at future boards. With regards to the cancer performance enclosed, what you're seeing reported is the end of Q2. Again, just a headline to the board coming into Q3, the month of November, and Q3's performance again will show a downturn in our position against the 62-day performance, because we had a number of super surgery days where we actually treated the patients. So it's a good news story in terms of patients being treated and receiving that treatment in timely fashion, although late. But obviously, performance-wise, we're penalised against the number treated within that time. So that will be forthcoming. From a diagnostics point of view, again, you've heard me report over recent months the real challenges we had, particularly with the imaging capacity. November clearly shows the green shoots, and we've subsequently improved with our MRI performance. We've got 2 more mobile units in recent months, and we are beginning to clear the backlog on that, so much so that we might be offering capacity to others that we're really motoring back through that pathway. I'm happy to pick up questions, challenges ahead, but obviously not reporting to them.
Do you want to go?
Thank you. Obviously very challenging times, especially all the strikes and things. And it's great to see just on the complaints response trajectory back up. That's really good. I'm curious as to why we had that, but
You look at Kate.
Yeah. The last one, I think. Speaking about, we're doing some data validation around how we measure complaint response times, just making sure we're really detailed around making sure that we're handling delays in the same way consistently and where things are delayed. I've got a paper going back on that too, and quality committee next time. Because we started being a bit more sort of robust around maintenance delay. And so, for example, if there's a delay and the patient agrees to an extension, do we count that as a delay? So just making sure we're all consistently applying the same reports on delay.
thank you. The other question I had was on RTT clearance trajectory. Seems to be kind of going straight up.
So we've been focusing on the long waiters, and clearly the focus has been our 78-week, as I've said, has been challenged. They are the more complex patients than patients that we haven't managed to necessarily find the additional theatre capacity or need more people involved in those cases. The 65-week has been coming down, but under 65 weeks, which reports the 18-week, is still on a trajectory. We've done a large piece of data quality and validation that will bring that down, but the focus at the moment is around 60 clearing at the end of the year, which will be a challenge now given what we've faced with the lost activity recently, and should it continue.
So would you expect that to continue?
We need to speak.
The two of you are talking.
Sorry. I know it's difficult when you're sat next to somebody, you feel like shouting at them, but we need to.
So our RTT performance will improve as we reduce the backlog and continue to shorten waiting times. We'll come on to how we do that later.
Thanks.
Kate and John.
One was a totally related point. The previous boards had questions around the overdue NICE guidelines, and they're still flagging on this report since November scorecard. As of January 2nd, that number should be 17. We've put all of our NICE documentation out in radar, so that we've got a different tracking process and validation process around breaches and follow-up actions. And I've got a paper report to catch that. Needs to be on civil side.
There's more one about presentation from you to help me to understand things. I'd be quite keen to somewhat visually get an understanding of what the key things are that are impeding flow. I've heard things as we've discussed, it's sort of imaging, access, the super stranded patients. But what are the sort of top 3 or 4 things that you're saying? If I solve those things, we can push more people through the hospital. I'm not quite. The stats don't quite allow me to see where the focus is. Is that making any sense? And it might be me, and I might be missing it, and you may have actually told me.
Yeah, that would be good, wouldn't it? It's quite an intricate thing. And it's hard to pin one causal factor as being the magic bullet. Is my immediate response today. But we've had big problems in certain areas.
Could I just sort of I think it's absolutely the right conversation to have in the seminar. There's one thing that was highlighted, which I think we have lost sight of a little bit, is I think we've now lost more than a month's worth of elective activity through doctor strikes in the last year. And that's huge. When it becomes cumulative, like that's a huge impact. And so it absolutely doesn't answer your question. It's just something that when we look at waiting times and where we've got to, it's not surprising we're not making it.
I think because it is complex and there are many ones to get to the 3.
No,
it would be good to spend some time on it rather than trying to.
No, but it's just so I can see the links between things like the manpower report, availability of staff in various areas, wards, where are we focusing, where do we need to? I'm sure you're doing it, and it's just so I can get visibility.
I think at one point we're going to see really on 7 in the summary header, there are no key points listed, and I didn't know if that was deliberate that there are no key points.
No,
they weren't, so it's just deliberate that it's fine, because I need to just work this population, if that's the case. Yes, yeah, fine, then people look like if someone else was looking at one project, that's a good. Oh, sorry,
So before we move on, we've jumped over the biannual safe staffing report. You might want to put it at the end, but I just wanted to alert you to that.
Okay, thank you. Shall we move to the final?
Okay, so the finance report is on page 214 of the pack. And that's reporting on month 8, so to the end of November. So we reported a cumulative deficit at that point of 2.3 million, which is adverse to plan. The monthly result for November actually showed a surplus. So we had a surplus of 0.7 million. And that's the 4th month in a row where we've had a surplus. So you'll remember the first 4 months of the year, we had we had deficits. At the high point of that deficit was month 4, when we had cumulative deficit of 5.9 million. And as we've been reporting surpluses, we've gradually eroded that down to 2.3 million at the end of November. So that was an improving position. And that really was driven, I think we've referenced it before in other reports, by recognition of ERF income, which is the elective recovery funding, due to us being able to maintain our elective programme, but also continuing focus on cost control and savings. So in total, by the end of November, we've recognised 6.6 million ERF, which is very, very significant. That wasn't included in our budget, so that's really helped out the financial position. And the activity level underneath that is around about 121%. So compared to pre-pandemic levels, we're operating at a level of 21% above that.
I would confirm that, because I think we've seen a report before that said we were at 130 or something like that.
So that's the cumulative position. So
not from you, Daphne, it was from reports, from data that come down.
Yeah. So actually, at the month of November, we had around about 130%. So maybe that's what it is. So November was particularly high because it was one of the few months where we didn't have strike action.
Just sorry, can I just come in there as well? Worth saying, I think we are deliberately being relatively prudent in terms of our financial assumptions associated with our activity over performance at this stage of the year. So that might also account for an element of the difference.
Yeah. Okay. And the other thing is, in earlier months, we didn't have any published data. We were having to do a lot of forecasting ourselves. The published data has started to catch up. So we've got published NHSE data now for the first 6 months. So that gives us a bit of reassurance that we will be paid.
That's what I was referring
Because
to.
the NHSE data was showing us as a number that we said we thought, maybe we said we didn't think might be that high. So that's exactly
Right.
Yeah.
Just, we don't want to be over optimistic.
Absolutely, yeah. Because so for the end of the last reporting to the end of November, we had 6 months of published data, 3 months where we had to do estimates ourselves. So we're always very cautious around what we report in terms of in the financial position. Okay, so that's the year-to-date position. The forecast in the report stands at break even. And at the last board seminar and the Finance and Investment Committee, we talked about a reforecasting exercise which took place in November, which was an NHS-wide exercise. And we looked at our numbers then, and there was a revision of the target for ERF and also some additional money. So at that stage, we reported break even. Now that predicated that there would be no further strike action. And of course, we've had 2 strikes since that time. And there is a financial impact to that. So we have signalled in our latest reporting, which is month 9, that we will return a deficit around about 10 million clients. and that reflects the cost of the two strikes, the strike in November and also the strike in January. So that's, and the cost of those strikes is a combination of staff backfill costs and the lost activity and the lost in the forecast, and that's in keeping with NHSE latest guidelines. So the LMK is also reflecting a reforecasting of their position to a deficit position. So that's what I'd say on the forecast. And then the final area I'll touch upon is next financial year. So normally we have financial guidance issued on Christmas Eve, but that didn't happen this year. So things are behind the usual timetable. Treasury approval for 24-25 is still outstanding. And so we've no timetable as such to work with at the moment. But what we do know is we're likely to get technical guidance out in January, and the submissions will be due, probably a submission at the end of February and another one in March. Meanwhile, we need to continue with our financial planning. So the teams have been very busy working, the finance team, with operational and clinical colleagues, putting together the bottom-up plans. That's just nearing completion, and then we're going through a series of meetings over the next week or so to come up with our plan, and then that will work into the national process over the next few weeks. One thing we do know, so we've had some guidance, but not complete guidance. One thing that we have been assured is that the ERF scheme will continue into next year. So £3 billion was put aside for the current year for incentive payments for elective recovery. That's the same amount of money has been put aside next year. So that's likely to continue, but we will await the detail on targets and the conditions around that. But they have assured us that it's likely to be a similar scheme to the current year. So that's all I was going to say around the finances. So we've covered the current year and looking forward to next year as well.
I was just struggling to reconcile. So we're planning a deficit. I hear your point about it really being 2 million, but the control deficit is break even at the moment in here.
Yeah, so
And
that
sorry,
was at a point in time, which is the end of November.
and
We will not to take further industrial action, even we began to know somewhere at that point that it might be coming, but that was the way the system was asked.
and I can see that the level of donations are down by about 7 million. What I can't quite understand and reconcile that picture with is the 20 million forecast shortfall in the cash at the end. Circa. Yeah.
Right.
So how do you bridge your P&L with your cash position?
Okay, maybe if we take that detail outside because we're more of a technical discussion.
Yeah.
But the donations is very much not related to supporting the revenue position, but that's a capital.
And just for the rest of the board, why I'm asking the question, because our cash is going down at a level quite significantly. And it's circa 20 million.
I think if you do that separate, at least shareholder we could do a session at 9, but we could quite interesting. I can't come to it, so I have to do it as a separate.
Yeah.
I think it'd be worthwhile just going into that, making sure it's one stuff.
Yeah. Of course, yeah, we could do that outside the meeting.
Thank you very much, Catherine. Okay, thank you for the team. Workforce report.
Thank you. So it's on page 209 back. So the metrics continue to perform very well, apart from the appraisal metric, which unfortunately has dipped down 1%, just under the target of 90%. But there's lots of work going on across the organisation to get that back up to 90% again. And also the turnover has come down consistently throughout the year. It's very nearly at target, 12.5%, so another 0.5% to go, and we'll get there. So that's positive news. Temporary staffing usage has been a big focus for myself and Yvonne over the last probably 2 to 3 months. We've been working really hard with the rostering team to make sure that all the international nurses who have joined us qualified, got their OSCEs, are now moving into their home wards. And that will really help our temporary staffing usage now going forwards, as I think pretty much all bar 3 have now got their OSCEs and are on embedded into the wards. That's a really good news story. We're now looking agency usages. We've introduced new controls over the year and they've been very successful. We're now looking at bank usage and perhaps mirroring that, especially now we're in such a good position with our establishment. And you can see that's reflected in the headcount, which continues to increase. Staff sickness is still under the target, not a target, but under the threshold. We expect that to go up slightly over the winter period with winter coughs and colds, but still managing that along lines of our policy. The other things to note in from this paper are that the Freedom Speak Up team have now moved into their new office. We've been doing some moves around the hospital, and security team who were based outside the Eaglestone restaurant in an office there have moved into their new base near A&E, which has allowed us to move the Freedom Speak Up team into the office they vacated. So that's much more public, easily accessible area, a bit more higher profile, a bit more footfall. So hopefully the Freedom Speak Up team will get more people just knocking on their door as well, which is another avenue for people to contact them. And the trust is signing up to the NHS Sexual Safety at Work Charter. So we'll be doing that. We already have lots of policies and procedures in place to support people, including our domestic violence policy and our regular HR policies. So we will continue to support people through that. We are signing up to that charter. The other thing to note is just the payroll changes that are coming in the near future. We have now we've moved to a new payroll provider. We have a little bit more flexibility in the roster time period, the roster periods we submit. So we used to have to close the roster at the very slightly before the end of the month before to make sure we made it into the next payroll. We've been able to extend that slightly now. So the roster period people receive their enhancements for will be from the 1st to the 31st, which just makes it a little bit easier for people to work out when they're checking off their pay slips. So that's good news. That's it. Thank you. Happy to take any questions.
Thanks, Danielle. Great news on the turnover figures and also the vacancy rate. I was looking at the scientific and professional at the beginning of the year, and that's like half, so that's really, really great to see. My question, I was looking at the model hospital, and I noticed one of the indicators, the WDES2 indicator, wasn't very good for us. In fact, we were kind of bottom and higher than that. Just curious to know if you have any thoughts around that. It's
so I know there is one WDES indicator which is actually the other way round. It looks we are showing us red because we're far away from the pack, but actually we're one of the best for it.
okay.
So I don't know if it's that one. I'd have to take it offline
Sure.
to check
Yeah,
that.
it's the relative likelihood of non-disabled staff compared to disabled staff being appointed shortlist.
I don't know if I have any. I'll have to have a look.
Sure.
You could take that actually.
Yeah.
But workforce.
Yeah, we can look at it in workforce committee. Yeah, absolutely.
I was only going to ask a question into kind of the obviously in terms of vacancy rate, obviously significantly moving on the period. And yet we've grown our staff cohort overall. I suppose I was just thinking where we've reduced capacity in places, has that partly helped that? Or is that not relative to that?
So our vacancy rate continues to decrease against the backdrop of an establishment which continues to increase.
Yes.
So I don't think we've had any areas where we've reduced capacity. We've just continued to do. We've increased and the team have run faster to fill the gap and whilst reducing the vacancy rate.
It's part of the conversation with the government. Nice to know because our establishment continues to grow in size. But it did make me ask the question of where we reduced, where we closed ward. I just wonder whether that was causing some of the reduction, but you're right, the overall number of staff continues to grow, so it's against that backdrop.
So in terms of when we opened the new ward, so we closed 2B, but we didn't have it in establishment. So when we built the medical centre, we moved the ward into that. So we didn't really add the establishment for a new ward. So when we closed it, that was reducing our escalation. When we open it, that reintroduces our escalation, but that's not the escalation staffing isn't in our establishment. The team the Yvonne's team and my team achieve that through bank and efficacy and moving our people around on top of our regular establishment numbers.
You've got to watch, so the bank, we've asked for some detailed work that Danielle and I are very regular things again. We've really managed the agency very well and are now, we need a forensic look at bank and to be able to explain that we're using bank. So we might be using bank on a ward, but we're moving a substantive member of staff to escalation. So it's really difficult to unpick some of that, which we're trying to do.
Is that thing that once I'd answered the question last night, we discussed it, I thought, hang on a moment, am I not clear about Ward 2B, for example? But that is what I would have thought, actually, that was to understand. Any other questions for Daniel? So Yvonne, I think we'll just go back to yourself.
Yes, that would be timely to move on. So colleagues, this report is the nursing and midwifery biannual day staffing and inpatient establishment review. And it comes back to Gary's points, the inpatient establishment review is adult only. It's not about maternity, which is birth rate plus, so it's slightly separate. As Danielle has already highlighted, from a registered perspective, we're in a good position in terms of our vacancies, and they continue on a declining trajectory. The area for concern and an area where there's detailed and focused attention is on healthcare support workers. We have a healthcare support worker steering group to try and recruit and hold on to. So recruiting these colleagues is more straightforward than retaining them in post. So the steering group is looking at a number of things. It is looking at education and training, so in particular the completion of the care certificate. And then that care certificate opens doors for our healthcare support workers to go on apprenticeships and extend their training and development. Part of that work is also looking at the pathway from band 2 to band 3, so that there is a good career development pathway available to those colleagues. We have been collaborating with BLMK on a system-wide recruitment campaign for healthcare support workers, and then that will then subsequently develop into more retention activities around this very important. We do expect through the BLMK, I think that is anticipated to come down by 40%. However, the real test of that is how do we retain those colleagues in those posts? So that's an area of continued focus and attention for me in particular. You'll have noted the reduction in agency spend. Our next steps will be to focus then on bank, as we previously discussed. We've done an awful lot of work on bill rates. So that comes back to your question, Heidi, about we don't want our fill rates to drop below 90%, and we've maintained that pretty much across the board for the last 6 months. But we've been able to maintain that while also staffing escalation areas. And so the escalation area can badly affect that. So we've mitigated all of those risks. Of real note in this paper is we have introduced a much more robust safe staffing escalation policy and process. It's entirely digital. We go through individual wards and look at how they're staffed. So, and this comes back to, again, what Gary said, it's not just about number or the ratio, it's about skill mix. So we're in a really good position now to start to think about how do we ensure that our newly registered nursing colleagues have really good talent management pathways, that it is about qualifying in specialty. And I'll talk about that in a little bit more detail when we go into the establishment reviews. So you'll notice that we've got a new component, which is the red flags, and they're increasing the number of red flags. That's a positive development for us as an organisation. It means that the ward areas know how to raise the red flag and say we've got a staffing issue. So the staffing issues can be not related to the number of staff who are available on the board. It could be to do with the acuity and dependency of the patient, and so we're increasing those number. You'll see that we mitigate them on a daily basis. So they're the main areas around the vacancies. So to now focus on the inpatient establishment reviews, you'll see in the paper that we did complete a formal establishment review using an evidence-based tool called the SNCT across all of our inpatient areas. You'll see in the recommendations there we have made some recommendations about tweaks to some night staff, but for the most part the area of our attention and focus will be on the emergency department, and on paediatrics. So the emergency department, comes back to your question again, Gary, about the numbers. So we won't be changing the numbers of nurses available in the ED, but we will be changing that skill mix. So similar to the conversation we've had about the neonates, we'll be looking for more nurses who are qualified in specialty, who are qualified to operate in ED and reduce the number of foundation nurses that are in the emergency department. So that's what the focus of that. So broader than the numbers and more about now the skill mix. Similarly, we've looked at the inpatient paediatric footprint, and in particular in the next establishment review has already started. We do them in 2 phases, one in the summer and one in the winter. We will be looking at our under 2s and how we would establish to reflect the number of under 2s we see here in Milton. So a positive step forward, and that is the safe staffing.
Just a quick question. I'm assuming within the manpower committee, because these numbers, a lot of them in combining with Daniel's are at a high level. And your point is, as you deep dive into them, you begin to see specific skill gaps that maybe aren't that evident to some of them. I'm guessing that in the committee, those deep dives occur where you break the numbers out and you see that within a category, you actually break it down and see where the gaps are.
So we do deep dives in the committee. We haven't done one into that particular issue for a while. But
That's more generic.
We also do an annual workforce plan where we look at where we're going to be 1 year, 3 year, 5 years, and we submit that nationally. And that goes into line by occupation code, what we think we're going to need, where we think we've got gaps, where we're going to get those people from. And that's a mammoth spreadsheet we have to submit every year.
And one follow-on question, I realize I don't, but do we have any? We've done a brilliant job on this, by the way. That's the context of where I'm coming from, by the way. Well done, you. But in terms of colleagues that we've brought in from overseas, do we have any concerns around how that may flow out over the next year or two, with maybe people wanting to go home, or because we've been quite dependent, and there still are, on them coming through and getting all the qualifications, and I just realised I don't know.
It's a really good question, Gary. We've got a dedicated steering group that's specifically about. We've got a coach that's been put in place for. It's dedicated for our internationally educated nurses. What we need to look at, and this work has already commenced, is that we have recruited a number of colleagues who are both experienced and newly registered. So while they might have come they might have been internationally recruited, some are newly qualified, and we'll take them down a newly qualified route. Some aren't, and so we're looking at those colleagues to ensure we have them on the right, in the right increments, as in they're sitting, their experience is reflected in not only their pay, but actually their grade. That process has already started. What we need to do next is we're focusing on all of this qualification and specialty, regardless of where people are recruited from. So giving us more resilience, and a good example, giving us more resilience in theatre. So people can do anaesthetics and they can work in recovery or whatever. And so that now that we're getting to this very unusual position of having very reduced vacancies, we now must look at that retention piece about, and nurses need and want to learn more, extend their skills. Joe has commissioned a piece of work that's around advanced practice. We must maximise on advanced practice opportunities for all of our clinical teams, and actually to benefit both patients and staff. So that's where the attention is going to focus away now into the retention piece, and I'd expect that you'll see more of the retention described in the papers as we move forward.
It's really helpful, thank you.
But generally speaking, retention's higher.
It is. I was going to remember that. So we've, I think we've lost 3 from 225 so far, which is far better than any other trusts have done. One, I think, has returned back to the home country, and the other 2 have moved to different places in the UK to be near a family in the UK. But as Yvonne says, we're working really hard now to make sure that we recognise all that experience that they bring with them. We give opportunity to move through the bands and the grades as quickly as we can for those people who are experienced. And I think it was at the last workforce committee we talked about the award we won as well as a trust for the pastoral care for bringing on boarding the internationally educated colleagues. the team, I think, did an amazing and fantastic job, far better than it's gone far better than we could ever have envisaged at the beginning. And we, as I say, we've done an amazing job at that. So all credit to Yvonne's teams and my teams who've worked really hard to make sure that these colleagues feel supported and are able to become part of MKUH.
Thank you. I'm all done again.
I think there was 2 hands up.
No, yeah, it has to be emphasised how well you've done. Congratulations. That ripples out beyond this room. Allied health professionals. How was it?
I didn't mention them in any great detail.
Yeah, I wondered if I remember years ago, I was being hopeful that would be a way of relieving the pressure on the other type. Is that panning out the way you expected?
So for the last 6 months, our activity around allied health professionals has been recruiting against their vacancies, particularly in areas that have been hard to recruit to. Now that we're in a better vacancy position, we've shifted that attention to exactly that question is, and this interestingly brings in the healthcare support workers. We're bringing more healthcare support workers in to be trained as therapy assistants and to be incorporated into part of the ward teams. So we're now trying to imagine different ways in which these colleagues would work together. Legitimately, I have a really good challenge around Ward 14, which we've established as a nurse-led unit. It doesn't have to be nurse-led, it can be led by an AHP and might be better led by an AHP. So we now need to explore those roles, both from a regular registration point of view, but also from an advanced practice.
And is there any challenge with clients with nice standards when you want to use an AHP?
No, it is trying to imagine different ways in which these. The most important bit from a regulatory point of view is that an individual is registered, and then we can work backwards from there.
I was thinking, just in particular, what your comment around the roles, and I think with currently there's a huge challenge going around on our business rates for OPs as well, and so it's so good to.
And the other part is I quite like to see the nursing. So we've been really good at the nursing associate role, and I know it doesn't hit from an HP perspective, but we've trained these individuals, these colleagues here ourselves. We now need to make sure that we're not closing off aspects of care delivery. So there's no reason why we couldn't have nursing associates in critical care. It might actually help us to reduce our agency's bit. So all of that has become real focus now that we can recruited as well as we are. And just probably to mention that the vacancy rate is much lower than what we've reported in this report. So
I've got Darren because John's about to dive in, but then John, and then I'm going to because we are. I'm failed miserably to get time, and I don't want to knock on the next issue too much.
Just to that point, I think there's the new AHP preceptorship agenda, and I was mentioning to Danielle about that, and that might sort of feed into that. If you look at how
that area now aligned is really helpful for all of us. I'd like to really bring us all together.
I had a separate question about the red flags actually, and it's great that obviously there's better reporting and the numbers are going up. But is there an impact on the quality of service delivery or patient risk or patient harm? How does that relate?
So the red flag is the red flag when it's raised allows us the opportunity. So me as the chief nurse and everybody who sits around my leadership team, we would be on the wards looking at who needs help and who doesn't. And so the red flag is more about an opportunity to flag that you've got a concern in a particular ward area. So we might, it's really interesting because you might move staff from an area that is more, it might have a better skill mix, if you like, and you might move someone to stabilise that particular ward area. So it's creating that visibility around the red flags. For the most part, we mitigate that. We have conversations now on the site meetings. It probably would be helpful to have a board seminar about what that looks like. It's difficult to describe to you, but we use the sunburst and the wheel to describe where our issues are and how they're mitigated.
John. Oh, just by way of organisation, maybe 40 used to be managed by HQs. So perhaps we could, people old enough, just find out what happened.
Thank you very much. Thank you very much, Yvonne. Risk register.
Thank you. There are, I don't anticipate going through the risk registers. The corporate risk register and significant risk register are both here, but for this from a transparency perspective, really. And the sort of kind of ledger sort of transactional report summary around risk management in the organisation and coming on and being rescored is summarised and covering the areas. It's here to note and that's great and for transparency purposes. Yeah, board assurance framework. Obviously, we had a session last month around renewing the board assurance framework, and I've summarised what we captured as part of that session in the covering paper. Next month, I'll bring those back as the BAF. So I'll work with those with exec colleagues around that becoming the new refreshed board assurance framework. So the paper will look quite different next month, and also taking into account the work that we've agreed that we will do around risk in terms of improving the reporting and sort of setting more in the risk environment context, etc. So that will come back to the seminar before it comes back to the larger public board.
Forward agenda planner. Are there any comments on that? Thank you for that.
Sorry, Heidi.
Yes.
Is this last year's board agenda? Because if 23, 24, I thought this was this like looking forward, not. It just looked like it hadn't been updated.
Yes, I think it hasn't been, has it?
Okay, I'll make sure we've got
Well, I suppose from an annual, oh yes, well, January 23, 24, that would be January of this year, wouldn't it? We'll check, can't we?
Yeah.
Thank you.
You can join Ian's club.
Yeah, I think we're all joining the club now. Are there any questions? I'm not worried. Thank you. And before we move to close the meeting, I'd like to thank Bev and Ralph Woodmanton for amazing contribution. I think you've been fantastic colleagues to work with. You've done all the really saving important plans. Getting really good discussions going. It just makes your workshops interesting. With me not realising you weren't there in January, because it isn't January, it's February. But again, thank you very, very much from the board for everything that you've given to WVUH, and we're very sad to see you go. There is a plan and something. So I'll move to close the meeting, and that's the end of the session. So if we come look at 22, is that all right? Yeah. Thank you.